Welcome, dear students, fellows, and colleagues, to today's webinar, international webinar in critical care today from our group Young India Intensivists. And today we have a very special faculty, Dr. ADRIAN Wong. Dr. ADRIAN Wong is very well known in the international faculty webinars, and he takes many webinars and is actively involved in teaching. We are really grateful to him, and we thank him for sparing his time and teaching all of us today. So just to briefly introduce Dr. Wong to those of you who may not know him, he's a consultant in anesthesia and critical care at the famous King's College London. And very importantly to the topic today, he's an ultrasound course director for the Intensive Care Society UK, the International Fluid Academy, and the European Society of Intensive Care Medicine, ESICM. It will not be wrong to say he's one of the foremost exponents of ultrasound in the ICU today. Then moving forward, he's chair of the Editorial Publishing and Communication Committee and a member of the Executive Committee of European Society of Intensive Care from 2020 to 2023. And he led the update of international consensus recommendations based on a Delphi exercise. And this made recommendations for intensive care internationally in 2020. And Dr. Wong has received various awards during his career, and he has published a great number of publications, which total more than 350. So we are really grateful to him for contributing to the teaching on our platform. And I hope this is really a big help to everybody, since ultrasound is becoming more and more important in the ICU now. So thank you, Dr. Wong, and over to you, sir.
You're very welcome. Thank you very much for the kind invitation and even kinder introduction. So what I'm going to talk to you today about for the next 40 minutes or so is why I think everyone should perform ultrasound, not just cardiac ultrasound, not just ultrasound for vascular access, but ultrasound head to toe. A couple of my disclosures, these are a couple of organizations I work for. None of them pay me very well, so they're not going to influence what I'm going to say to you today. Probably my biggest declaration or conflict of interest is the fact that I genuinely believe that if you look after an acutely unwell patient, be it from a surgical background, anesthetic background, intensive care background, emergency medicine background, you should be able to do some form of ultrasound. It's important to remember that in the context of what I'm going to talk about, I'm not training or encouraging you to become radiologists. I'm encouraging you to become better anesthetists, better intensivists in your own specialties. And I'll highlight some differences in what I mean during the course of the talk lecture. So what I'm going to cover the various different modalities when it comes to whole body ultrasound, with particular emphasis on anesthesia and intensive care. And then I'm going to touch upon maybe some potential future directions of where I think it might head. So I hope I don't have to convince you that there are real benefits to the use of ultrasound in our day-to-day clinical practice. Unlike our radiology colleagues who, generally speaking, do the scans in the ultrasound department, radiology department, when intensivists and anesthetists perform ultrasound scans, is by the bedside. We're trying to answer a clinical question. For example, is this patient's left ventricle functioning? Is there a pleural effusion? When I tap the pleural effusion, drain the pleural effusion, what does the lung after that look like? So it's very clinically orientated. It tends to be very focused questions as well. If you look at the programs that spell out critical care ultrasound, perioperative ultrasound, the questions that are asked are generally binary. In other words, is there severe left ventricular failure? Yes or no. Is there pericardial effusion? Yes or no. So it's very different from the approach taken by some cardiologists. It's very different from the approach taken by radiographers and radiologists as well. As already mentioned, I think that the ultrasound machine, the devices, and the skill has moved well away from the radiology department. So within most intensive care unit, most operating theaters, most anesthetic department, you will find an ultrasound machine of some form. From the left-hand side, they are the bigger versions that, generally speaking, tend to be still in the radiology department. The one that we're more familiar with, perhaps, are the ones that are somewhat in the center, so cart-based, so you can move them relatively easy from patient to patient, bedside to bedside. And I'm sure most of you are also aware that with technology, the advent of more handheld devices, such as the device shown on the right-hand side, is becoming increasingly common. I think most anaesthetist intensivists amongst you would be familiar with ultrasound through the use in vascular access. So this is just one of the more recent guidelines from the European Society of Anesthesiology, encouraging the use of ultrasound to guide vascular access. I appreciate that not everyone does it. The landmark technique, certainly for some particular sites, example, there's a Playbill one, is still very much in train. But I think the barrier, that is the lack of device, is becoming less and less common. So you're familiar with ultrasound guided vascular access already. The next obvious next step forward is to look at all the other organ systems. And I'm going to show you all the other things that you can do with the ultrasound machine that you already have in your department or in your ICU. So when it comes to resuscitating or examining the patient, most of us have an airway, breathing, circulation, disability, and everything else approach. So the ABCDE approach. And this slide just summarizes that with ultrasound, you can assess A, you can assess B breathing, you can assess circulation, you can assess disability, and you can just, well, really assess everything else using ultrasound. And for the remainder of my talk, I'm going to walk you through all of this and then put it all together in some form of protocol, some form of approach. Most of us, as I understand it, are anesthetists, are intensivists, so you have some form of familiarity with what happens in the anesthetic side of things. The concepts that I'm going to share with you now are applicable regardless of whether you spend the majority of your time in the intensive care setting or the anesthetic OR. So let's start with airway ultrasound first. As part of your duties as an anesthetist is to, well, some would argue the most important thing that you do is to manage the airway. And part of managing the airway is to perform some form of airway assessment. You might look at it from an observation perspective, but more and more now, especially when you think that airway is going to be difficult, you're going to examine. And I would argue and encourage that if you think that airway is going to be difficult, perhaps you should consider the ultrasound. And these are the different structures you can see using an ultrasound device. You can definitely see the cricoid thyroid cartilage. You can feel the tracheal rings much more accurately. And using ultrasound, you can actually evaluate for the placement of the endotracheal tube. You can measure the size of what tube to place as well. These are quite advanced skills. For a very nice summary of it, I would encourage people to read this very nice review article by colleagues based in Malaysia. Adi Osman is an emergency medicine critical care consultant who has done extensive work on this. And I'm just going to highlight this particular study when it comes to airway management. So the anaesthetists and intensivists amongst you would know that in a can't intubate, can't ventilate scenario, what your emergency technique is a cricoid direct puncture of a cricoid direct membrane. Now, what this very nice randomized controlled trial did was to basically say, okay, if you palpate and then mark where you think you are, how does that compare to an ultrasound examination? So the red dots is palpation, and the blue dots is using ultrasound to mark the target, in this case, the cricothyroid membrane. As you can see, The blue dots are very much centered around the target. Perhaps more worryingly, you can see that with palpation, the spread is everywhere. And in some cases, you can have up to 3 centimeter difference in the vertical axis and 3 centimeter difference in the lateral axis, will make the difference between what people thought they were and where they actually are. Ultrasound reduces that variability. So that's it. Airway. Let's talk about breathing and the lung. For those of you who are perhaps novices when it comes to ultrasound and you want to pick up the skill, I generally encourage people to start with the lungs. The reason why I encourage people to start with the lungs is that it's rather straightforward to learn. And as you practice, you will find that you will see pathology. And part of the learning process is to recognize what's normal and what is abnormal. And if you work on the average intensive care unit, the average emergency medicine, you will find pathology. So just to highlight what this is then. Okay, so let's go laser pointer. So that's the rib shadow here, a rib shadow there, and there. This center bright line below the ribs is where the pleura is. And as you can see, as the pleura slides back and forth, you can see it sliding. That is known as pleural sliding. You can occasionally see horizontal artifacts, and those are called A lines. And occasionally you see vertical artifacts, and those are called B lines. So horizontal, A, vertical, B. You are allowed more, you normally have less than 2 B lines per rib space. And the way I would think about B lines is the sonographic version of crackles. So if you hear crackles over an area or a lung that you're auscultating, the differentials that you might think, is this infection, is this pulmonary edema, is this lung fibrosis, you know, that sort of thing. Compare that to these images. And as you can see for these images, there are lots and lots of vertical lines and lots of B lines. So these are signs of patients who have got pulmonary edema or lung fibrosis, depending on the clinical context. Okay. So that's lots and lots of B lines, pulmonary edema. On to this one. Now, I think, as I said to you before, the line that is there is your parietal and visceral pleura sliding against each other. They are moving. Okay. And as you can, and we can put something called M mode here. I'm just going to illustrate the difference. Oops. And on the other one, this is probably illustrated better on this one. In this CT scan, there is a pneumothorax in that rib space. Okay. If you put the probe up here, you can see that line, that parietal, that top line there, a laser pointer, there, is not moving. To this bottom right image, where the lung is in contact with the inner side of the chest, parietal and visceral pleura are moving against each other, and you can see that sliding. So that's normal, and that one there is abnormal. Have a look at this in-between picture. So in this in-between picture, I hope you can appreciate every now and then you can see something shooting in from the right-hand side of the screen towards the left. And that is essentially your lung coming in and against the chest and out. Because when the patient is a pneumothorax, the patient is still breathing. This is real time what's happening in the patient's chest. So you don't have to get a chest x-ray, because a chest x-ray is just a single snapshot. This is in real time. Okay, on to the next one. This is what a pleural effusion looks like on the chest x-ray. So on the ultrasound, sorry. Under ultrasound, fluid, blood is black. And so you can see a very black space there, and that is a pleural effusion. Compared to the sensitivity and specificity of clinical examination compared to chest radiographs, ultrasound is far, far superior. Far, far superior. And with ultrasound, you can see things such as this. So this is a complex pleural effusions. You can see fibrin strands within that chest cavity, within the fluid pool. If you just had a chest radiograph, if you just examined the patient, you would have missed this because you wouldn't be able to see this. And in actual fact, the distance discriminator of ultrasound compared to chest CT means that you're more likely to see this on chest ultrasound and miss it on the chest CT. If you're going to drain it, the recommendations from the British Thoracic Society would recommend that if you're going to put one of these drains in, it should be under ultrasound guidance, okay? The ultrasound guidance reduces the rate of complications. This is the other thing you could see. So compared to what I shown you earlier with nice, straight pleural lines sliding back and forth, maybe that one's there a bit, but can you see that this one is very irregular? There are bits within it that have been punched out. This is evidence of subpleural consolidation or infection. Okay? Much more sensitive, much more specific compared to chest radiographs. So that's quite subtle. But have a look at these images which I'm now showing you. These are heavily consolidated lung. And the beauty of, again, as I said before, is that this is in real time. You can see things moving. So have a look at this one here. Can you see there's a white dot that comes in and out every now and then? These are dynamic air bronchograms. Dynamic because it's in real time and the patient is actually breathing. This is so different from a plain chest radiograph, which takes a snapshot at that particular time. Okay, so what I've shown you is different segments, but what you can do is to build up a picture of what the right lung looks like in the various different sectors and what the left lung looks like in the various different sectors. It's the same way as you would approach examining the respiratory system if you were auscultated. So you would listen to the various different lobes and put all the information together and come up with a diagnosis, some form. And the way you use it for lung ultrasound, this is a protocol, a diagnostic tree published very, very early on by the pioneer of lung ultrasound, Professor Daniel Lichtenstein. Don't worry about the different terminologies. What I wanted to highlight is the diagnosis. Pulmonary edema, pulmonary embolus, pneumonia, COPD, pneumonia, pneumothorax. Just think about it. Think back to the time that you were called to the ward acutely because your patient is short of breath. I would hazard a guess that 96% of the time of that patient who is now acutely short of breath, they will have one of these diagnoses, either pneumonia, COPD, so on and so forth, okay? So it is very, very useful. And just to show you that in the diagnosis of pneumothorax, pleural effusion, interstitial fluid, which is essentially pulmonary edema, the sensitivity and specificity of ultrasound is extremely high. And when you then compare it with clinical examination, so auscultating, chest X-ray, and ultrasound, when compared to the gold standards in most studies, which is CT scan, ultrasound exceeds that of clinical examination and chest radiograph. Okay? And because, like I said, if you work on any average ITU, you will almost certainly find pathology. When you learn this, you will see and recognize them. It will become very, very clinically useful. Just for the sake of completeness, as part of the respiratory system examination, what you could do now is to do a diaphragmatic ultrasound. So for those of you on the intensive care unit, you may have heard of this technique being used to predict patients' ability to wean. and patients predict ability to be successfully extubated. Diaphragmatic ultrasound. Again, real time, no guessing. You can see what the sound is doing. So that's your breathing. Let's talk about circulation now. So these are the standard cardiac ultrasound views of the heart. That's the parasternal long axis, that's the parasternal short axis, that's the apical four-chamber, and the subcostal four-chamber. Now, I think cardiac ultrasound can be intimidating at times because our cardiologists do it. They do lots of fancy measurements. They do lots of color things on the images. I would encourage you not to be intimidated by it. Take your time and look at the plain 2D image. You get a lot of information from it. And any fancy measurements that you are going to make or want to do relies on a good 2D image. So don't be distracted by the measurements. Focus on looking at the images, at each chamber, at each valve, very, very closely. In the business of intensive care, we are in the business of managing shock. We all remember and can regurgitate the various different classifications of shock: hypovolemic, cardiogenic, distributive. I like this Venn diagram. This Venn diagram essentially reminds us that although we describe them as separate categories, they can coexist. So for example, the septic patient, which classically has distributive shock from vasodilatory, has also or may also have a component of cardiogenic shock. Septic cardiomyopathy is increasingly being recognized, okay? So one step back, so these are images of very, very normal hearts, which I showed you. I'm going to show you images of not so normal hearts now. So have a look at these images. You don't need a cardiologist to be able to spot. The chambers are not moving very much. In my day-to-day practice, it matters very little to me whether the ejection fraction is 35%, or is 37% or 36% for the sake of argument. All I want to know, in this patient who's acutely unwell in front of me, is the left heart, right heart doing okay, doing good, or doing very badly? And that is a qualitative assessment. No fancy measures, eyeballing it and calling it. Another example of, well, now this heart looks big, so dilated, and it doesn't look like it's working, it's moving very much. So there's severe dysfunction. Parasternal short axis view. This is the left ventricle, which is supposed to be shaped like a donut. Those are papillary muscles there. It's not contracting very much. Under normal circumstances, that chamber disappears by about 50%, if not more. On to some interesting images. This is an interesting one. So this is a patient who initially presented with septic shock. We ultrasounded it and we came back afterwards, and you have now can see this bit. This is a blood clot that's formed in between these two scans. So the scan is repeatable. There's no radiation, and you record images there and then. And if you want to drain this, you can drain this under ultrasound guidance again. On to neuro ultrasound, which I have to admit is one of the perhaps the more newer ones. So believe it or not, despite the presence of the skull, with ultrasound, you can assess all the major vessels of the brain. So your middle, cerebral, anterior, and posterior cerebral arteries, you can image in a circle with this Alice illustrated in this diagram here. Most of the work and focus of transcranial Doppler has been on the use on the neurointensive care setting. However, there is increasing evidence to suggest that it may be useful in the general intensive care population, so trauma population as well. And I'll come to some of those recommendations later on. So you can look at the arteries that supply the veins of the brain, and you can look at the various different areas and the velocities of the blood flow within those vessels. The other thing that you can do using neuro ultrasound is something called optic nerve sheath diameter. So with that, it is generally or can be used as a surrogate marker of raised intracranial pressure. The way you do that is this. So this is just to remind everyone of the anatomy. This is your optic nerve sheath right at the back and up there. Okay. And what you're going to do is to measure. And you measure 3 millimeters behind the globe and across, and anything 0.5 centimeters is the cutoff I normally use. Anything above 0.5 is associated with raised intracranial pressure, and certainly should raise your index of suspicion. So if, for example, you work in an institution where CT scan is less available, this is the one way you can do it. Just to highlight the first neural ultrasound I showed you earlier, this is looking at flows within the middle cerebral artery, and generally speaking, you should never have reverse flow. And this is a patient who has had a significant traumatic brain injury. On to exposure now. One of the first utility of ultrasound outside of radiology was the fast scan, so focus assessment using sonograph in trauma. And in this situation, you were looking for free fluid in the context of a patient who's sustained trauma. So as I said earlier, fluid is black on ultrasound. You can see fluid in the context of liver failure or malignancy, such as this one here. And just again to highlight, this is in real time, so you see it moving. So if you were going to drain this, you can visualize where your needle is going. There. You can hopefully guide it away from that. You can avoid any other tethering, fibrin strands, etc., etc. So it allows you to pick your spot rather more accurately. And just to summarize now, instead of the traditional fast scan, there are so many other things that you can do in the abdomen. You can look at the gallbladder, you can look at the aorta, you can look at the inferior vena cava. Now, I've intentionally not spent a lot of time with the inferior vena cava. We'll mention it later on because I know that quite a lot of you, I suspect, would have heard of the ultrasonography of the inferior vena cava diameter and variations of its size as a marker of fluid status. I personally don't use it. I think there's significant, I don't use it by itself. I think there's significant limitations to it. And as I shown you earlier, that if you're going to drain it, you might want to use an ultrasound to help you drain the fluid because it is so much more safe, so much more accurate compared to just trying to palpate the area where you're going to put your needle to drain the ascites. Okay, so I've talked about ABCDEs almost in isolation. This is how you assess the respiratory side of things. This is how you do the cardiovascular side of things. We can all agree that part of our jobs as doctors, especially on intensive care, especially in anesthesia, is to put it all together. Put all these bits of information, the heart, the lung, the abdomen, and come up with a diagnosis, and then come up with a management strategy. So for example, in your rush scan, this is just a summary. This is just a summary of what the rush scan involves. So rush stands for rapid ultrasound and shock protocol. You look at the pump, you look at the tank, and you look at the pipes, the major vessels. And this is where you the different views that you'll be scanning. And the information that you'll be getting can be summarized in this diagram. So what's the heart doing? Is there a pericardial effusion? What's the left ventricle doing? What's the IVC doing? Is there free fluid? What do the lungs look like? Do they look dry? Do they look wet? So by combining all the different elements I've spoken to you earlier, you can come up with a fairly, or certainly more accurate diagnosis that will hopefully lead to a better management plan and hopefully a better outcome for the patient. Just to remind you that there are other protocols out there. This is one by Daniel Lichtenstein, who's based in France, and he calls it the Sesame protocol. He starts with the lung, but ultimately looks at the vessels, the abdomen, and the heart. Most of the time when I do any scans, I start with the heart, but this is just to make you aware that there are other protocols out there. I thought I'd illustrate how ultrasound is very nice in bringing it all together with when it comes to fluid management. And I hope most of you would have heard about the ROSE acronym when it comes to the different phases of fluid management: resuscitation, optimization, stabilization, and de-escalation. I know this group has had a talk by Professor Manuel Brain, so I'm very sure that he would have talked to you about the different phases. My bias, I think there is a lot of emphasis placed on giving fluids, so resuscitation, optimization, and yet we also know that fluids are drugs. Fluids can cause harm. So the latter stages, stabilization, de-escalations, are somewhat neglected, for lack of a better word. Okay. But again, I'd like to show you that with ultrasound, you can use it to guide your fluid management strategies, and we all give IV fluids, regardless of which specialty you work in, to help you guide fluid management, fluid status in all of the 4 phases. So let's start with resuscitation. I'm sure most of you are familiar with the passive leg raise test, made popular by Professor Xavier Monet, Professor Jean-Louis Debout. And essentially, it's a auto fluid challenge. Tilt the patient up, don't touch the patient while you're doing this, and it transfuses the volume of blood in the patient's lower limb into the chest, and then you're supposed to see if there's an improvement in your cardiac output. And the way you do your cardiac output using ultrasound, you can measure something called the left ventricular outflow tract, VTI, which essentially is the velocity of blood being ejected from the heart. And if you know what the area of that orifice is, you can convert that velocity into a stroke volume. Now, if you can't do that, or you don't know how to do it, just to show you that there are now software that can do it for you. So this is one manufacturer where the software will pick out the area of interest for you, and it will calculate the VTI in real time. So you can put the machine on, you can let it do its measurement, you can give your patient a fluid challenge or do whatever maneuver you want, and then it will measure it for you in real time, and you can track it. Such as this one. So you can track it there. I've shown you a couple of protocols. I thought I'd show you this one. The reason why I like this one is because in addition to the giving fluid and the fluid challenge, there is a component there that says restrict fluid. So in this case, if your inferior vena cava is very distended, not collapsing, you've got lots and lots of B lines on your lung ultrasound, it may be an idea not to give any more fluids and indeed fluid restrict them. Which brings me to something called the venous access ultrasound score. So hemodynamic management in medicine, in critical care, has generally speaking focused on the giving of fluid. We walk around the Tapas, do you want to mute your mic? Sorry.
Yeah, sorry.
Okay. Where was I? Okay, so generally speaking, we focus on the giving of fluid. And we concentrate on the arterial side of the circulation. So mean arterial pressure, what your cardiac output is, etc., etc. But perhaps what we're really interested in, or what we hope to happen, is that by maintaining good mean arterial pressure, maintaining a good cardiac output, you are optimizing the delivery of nutrients and you are maximizing organ perfusion. But simplistically, organ perfusion is not just a good mean arterial pressure. Organ perfusion is your perfusion pressure of that organ, and that is the difference between your arterial side and venous side. And it's only recently where this has somewhat undergone a renaissance. We're starting to look at the venous side of the circulation a bit more closely. And I would argue one of the key triggers for that is the development of something called the VEXUS score, as highlighted in this diagram. The rationale for it is actually quite simple. We know that ultimately the inferior vena cava collates all blood from the venous circulation to be returned into the right heart. If your circulation is very, very full, your inferior vena cava dilates. If your inferior vena cava dilates and is very, very full, the flow in the veins that lead into your inferior vena cava becomes more abnormal. So we'll take the hepatic vein as an illustration. Normal hepatic vein flows with two troughs, S and D, into your inferior vena cava. As the system gets very, very full, instead of flow moving very, very unobstructively from the hepatic vein into inferior vena cava, you start getting reversal of the flow. So instead of having that normal pattern, you have this pattern. Similarly, in your portal vein, your normal portal vein has a normal humming flow. It's not very pulsatile. And as the system gets very, very full, it becomes more and more pulsatile. And you read it for yourself. That POCUS 101 is a very, very nice website. Lots of simple infographics for you to take home the key messages and then do some further reading if you're interested. The VEXUS score here, published in 2020, I think allowed people to approach to assess and therefore study venous flow, venous congestions in a more structured way. I don't think it's perfect, but I think it's a start. Okay, so that's the venous flow. Other things I think you might be looking for is in the microcirculation. So let's have a look at this one. So in your microcirculation, you have, this is your kidney over here on the right-hand side. And this is injection of a contrast agent, which stays within the blood vessels. Your kidneys, you know, is a very, very vascular organ. And you can see on the orange image on the left-hand side that it is very bright. You can measure how bright it is. You can also measure how quickly it gets bright. So there are two things you can look at. Have a look at this one, though. Compared to the image I've shown you before, this one is less bright, but perhaps more obviously gets bright much slower. This is a patient with septic shock, with an acute kidney injury, which didn't recover. Okay, so there are early works out there by colleagues who share my lab, who have shown that if you can predict which patients who are going to recover from their septic AKI versus those that won't recover from their septic AKI based on the scan. Again, early works, but this is an example of using the microcirculation. So just to highlight what the normal looks like again, really, really bright, gets bright really, really quickly. Other things that looking forward in the future, so handhelds, as I said, we've got a couple of these and we use it for training purposes. The idea is, especially in the context of an outreach or medical emergency team or whatever you have in your institution, rather than pushing a large machine to the patient, you bring the patient, or you bring the ultrasound pocket size to the patient and scan by the bedside. And the beauty of some of this device, as shown in this diagram, is that with your smartphone, you can speak to your consultant colleague, your senior colleague, your experts remotely. They can see what you're scanning and how you're scanning as well. So there is real-time feedback, diagnosis, etc., through the use of these modern handheld devices. So watch this space. Now, I appreciate that that's a lot to take in, especially if you're on the novice side of things, but I hope rather than be intimidated by it, it encourages you and excites you somewhat about the huge potential ultrasound has. So if you're not using it already, I hope that encourages you to read up a bit more. And I think perhaps more importantly, go out and pick a probe up. Okay. To help guide you, the European Society of Intensive Care Medicine has published a couple of articles on what we think an intensivist should know. There are educational resources. I know the ones from the European Society of Intensive Care Medicine. So there are online resources, webinars, courses, so on and so forth. But we are not the only organizations that are doing so. So if you go online, there are loads of stuff out there. But what I think is nice about the European Society project is that it gives you everything in a nice pathway rather than just a one-off thing. I think as ultrasound and critical care develop further, I've already hinted that in my view, everyone should do a bit core. And if, let's say, you have an interest in neuro, you will develop more advanced skill sets that are useful in your role. If you work on a cardiothoracic center, say, for example, and you want to develop the skill set of transesophageal echocardiography, perhaps that is for you. I think perhaps more excitingly, if for the anesthetists amongst you, I'm sure it's the case in India as well and internationally, we are taking on higher and higher risk group patients. They're sicker, they've got more comorbidities. So the ability to scan the patient in a pre-op setting, look at the heart, look at the lungs, and be able to engage in some more meaningful conversation and stratify these patients with regard to risk is a very, very exciting area in the perioperative world. Okay, just again to show you the couple of colleagues in Italy and internationally have published this. So for those neuro-intensivist neuroanesthetists amongst you, they've discussed and presented a stepwise approach from the very, very basics to the more advanced skill set for neuro ultrasound. But you could argue that similar things should exist for all the other modalities, heart, lung, so on and so forth. In the UK, our program is called FUSIC, Focused Ultrasound Skills in Intensive Care. We have the British Society of Echocardiography that support some of the learning as well. So I hope I've shown you that really, if you want to do your job better on the intensive care unit, in the anesthetic department, you really should be using ultrasound. These are a couple of resources and colleagues. So Richard Fisher is my partner in crime. He's a really good friend, but he's also an excellent teacher in echocardiography. On YouTube, his channel, Foundations of Echo, has a series of online lectures that walks you through how to perform a cardiac ultrasound extremely well and in great detail. So I encourage people to look at it if you're interested. It's also free. So summary then, take-home message. I hope I've shown you that ultrasound enhances all the things that you already do. Managing people's fluids, trying to assess their airway, looking at their hemodynamics of circulation, all the stuff that you already do. I think ultrasound makes you better. I think it's also fair to say that it is a skill. And like any skill, you need to take the time, invest the time to learn it. Because ultimately, it's a tool. If you don't know what you're doing, I would argue that it makes it much more dangerous for you and for the patient. And with that, I thank you. Happy to take any questions, queries.
Thank you, Dr. Wong, sir. So for a lovely talk and very enlightening and showing the way forward to our young intensivists. Thank you so much. So I encourage people to put up their questions and you can put them up in the chat box. So Dr. Wong, while you wait for the questions, maybe I can just engage you in some discussion which will be helpful for everybody. So, sir, in India at least, a lot of people use the IVC as a marker of fluid responsiveness. This paper came out a few years ago that if you look at the IVC and a diameter of collapsibility, less than 50%, more than 50% can be taken as a cutoff, which we know is not really correct. But yes, the extreme diameter, can be taken as a marker of fluid responsiveness if it's fully dilated or fully collapsed. And we have numbers like 1 centimeter and I think 2.5. So first of all, your comment on this use of IVC as a marker of fluid responsiveness, especially in spontaneously breathing patients, because it's a very easy way, and at least in India, people are still doing this. And second, sir, what about the cutoffs for the diameter? Because is this not dependent on the height and weight of the patient? So that is another question. So these two questions, sir, first of all.
Okay, so with the inferior vena cava, I would never encourage people to do it in isolation, although I know people are doing it. They put the probe on and they see the IVC and they think, okay, I'm going to do X. I think if you're generous, the IVC in its extreme, so extremely enlarged with minimal respiratory variation, is useful. So probably fluid is not a good idea in this situation. If your IVC is very, very small and collapsing, then I think, okay. I think if you're going to image the IVC, all it takes is for you to move the probe a bit more to the right-hand side, to the left-hand side, and then you will see the subcostal four chamber. You will get an idea in terms of what the right ventricle, left ventricle size and function is with minor adjustments of the probe. I think there is a very nice article by Gabriel Villa and Susanna Price, which is the 10 times where the IVC is not useful. And that's a very nice physiologically based principle on why the limitation of IVC. The other thing I'd say about the IVC is that traditionally, when most people measure it, they measure it in the long axis. And we assume that the long axis is reflective of the normal underlying anatomy. And the problem is the IVC is not round. The IVC is oval. So when it matters a lot how you cut that oval section. So it raises two things. One, should you really be measuring the IVC not necessarily in the long axis, but in the short axis? So rotate your probe 90 degrees. Most people do not do that. When you look at the short axis view, then your variation in size and maximum diameter is probably more reflective of the fluid state. The cutoff I use as a gross number is 2 centimeters, okay? Because it's easy to remember, 2.1, 2.2, minor measurements in where you measure can make the difference. But as a ballpark, I think 2 is good enough. And again, it's just my practice. Never look at the IVC by itself. Look at the heart as well.
Right. Thank you, sir. So then, moving on, about the use of POCUS in renal nephrology, critical care nephrology at VEXUS, which is coming up. So I believe, sir, these are technically very challenging. Do you think, sir, young people will be able to acquire these skills, and what is the future with these kind of skills?
I happen to know that the nephrology colleagues, and some of which who are based in India, are starting to do more and more renal ultrasound. I think with VEXUS, I do not think is a beginner skill. So I don't think it should be the thing that you start off with. I think where it's useful for colleagues in renal medicine is to be able to say, is this patient who has got acute on chronic or acute kidney injury, have they got a hydronephrosis? That's one of the international recommendations. Anyone produced with an AKI or a acute on chronic kidney injury should have an ultrasound to rule out an obstructive component. Hydronephrosis, yes or no, I think is a core skill of nephrology trainees and nephrology colleagues. The optimizing the hemodynamics, I think, is useful. Looking at fluid balance in the wet lungs, ascites in the abdomen, I think is very useful. VEXUS, I don't think it's beginner. I do not think that we know everything about VEXUS, venous congestion in the kidney. But again, I think it's an opportunity to study more. There are papers out there now that started to focusing on a more practical perspective. When I was learning venous ultrasound, so VEXUS, I initially thought, okay, kidneys must be really easy to measure because it's so easy to spot the kidney. I know how to do it already. I should be able to do the venous side of things without too much problem. Practically, I think it's the most difficult because, annoyingly, patients breathe. When patients breathe, the kidney moves quite a bit. So it's quite challenging to get a stable Doppler gate over your area of interest in order to get a good trace to look at the flows in the arterial and the venous side. So yeah, some of my thoughts.
Thank you, sir. So then just another question. We understand that ultrasound is very useful in the ICU and we all use it. And now we are putting a lot of emphasis on seeing a lot of things, moving on and pushing it forward and making protocols for diagnosis. But at the same time, sir, do you think we should also be pushing forward the fact that acquisition of clinical knowledge and making clinical diagnosis is equally important, and ultrasound is probably being pushed too much ahead, considering that a lot of people who come into intensive care from anesthesia and medical knowledge is not that much? Do you think there should be more emphasis on acquiring clinical knowledge also at the same time, which would complement the use of POCUS?
First thing to say is that ultrasound does not replace clinical knowledge. It does not replace a good history. It does not replace an examination. It gives you an extra layer of information for you to then put together and come up with a plan. I take on board what you said about some people, and I'll use the example of vascular access as an example. I think in India as well as in the rest of the world, the use of ultrasound guided central venous cannulation is now almost standard practice. In the UK, it's certainly standard practice. Unfortunately, what I've noticed, and I think colleagues would share, trainers would agree with me, now people don't know the anatomy as well as before. When you learn the landmark technique, say for the right internal jugular, your professor, your boss, you probably remember, made you draw out the anatomy. You know the anatomy inside out. Where was the sternocleidomastoid, where the phrenic nerve, where the transverse process of the vessels of the spine is, cervical spine is, so on and so forth. Now, I think that colleagues have this misguided reassurance that when you're cannulating this internal jugular, you want that round black dot and not the triangular dot here, so on and so forth. They're aiming for a dot. They don't know the rest of the anatomy surrounding that vessel. So I think you can make that sort of similar arguments for all the other modalities. You must know, your knowledge must be sound. You need to know the anatomy. You need to know the physiology. You need to know the history. Do not treat an image. Treat the patient. Is my thoughts on your comment there, which is a very fair comment.
Yeah, I think, sir, that is wonderful, because the younger people are, forgetting the essence and the basics, taking the history examination, etc. So there's a lot of focus on ultrasound in the ICUs, at least in India. So learning the skills with the ultrasound, where too much focus, I think they're forgetting the basics. Finally, no, sir, there are no questions from the audience. One last question, sir. Since you're deeply involved with ultrasound and teaching and forming guidelines, etc., how much difference has ultrasound made finally, sir? It has been there now for a few years. It was not there earlier. So have we looked at the outcomes, after ultrasound has been started used in the ICUs?
In terms of what? Is it in terms of the training and how they learn, or?
No, in terms of the outcomes, patient outcomes, sir. Modality,
okay,
whatever.
Okay, yeah. So there are various different studies out there. So the biggest one on the use of transthoracic echo was a retrospective analysis of the MIMIC database, which is an American database system that stored all real patient information. And what colleagues based in France did was to look at all the patients that was treated in the American system and divided those who had septic shock into those that had echo and those who didn't have echo. And the ones that had echo had better outcomes. That's the first thing to say, okay? The initial trials of whether ultrasound benefits patients or not have almost always been no difference. The reason I think is because, let's say so you might think, why is that the case? If I could diagnose quicker, if I can repeat my monitoring much more closer, so on and so forth, why shouldn't my patients do better? And I think it's my bias, again, is when you and I look at the left ventricle, and most of the trials basically said, use ultrasound, and then with that information, the clinicians are free to do whatever they want. So let's say, for example, we use echocardiography as an example. You might have the left ventricle there, and we both agree, okay, the left ventricle is down. And that's the basis of the trial. You then go, okay, I'm going to use, I don't know, Milrinol. I'm going to use the butamine or levosimendan. So the management strategies have never been standardized. And that highlights a very important learning point to me, which is you can do all the fancy ultrasound that you want, but unless it's allied to a management strategy, it will make no difference. And you can use that saying for any monitoring device, not just ultrasound. The more recent trials, though, looking at glow-directed fluid therapy using ultrasound as the monitor, as a trigger, have shown some benefits. And there are more work in the background happening in terms of ultrasound-guided resuscitation. But certainly the initial shock trials done by emergency medicine colleagues didn't show a difference. And part of that, I think, was because what happened after the ultrasound assessment was not standardized.
Right, sir. So that is like so many other things. One has to know how to use the results that you get from the ultrasound. But but looking at it, definitely it's helpful. But then the young fellows should not just look at the ultrasound and echoes. They have to acquire clinical skills as well. The basics, like you said, have to be in place.
Yeah, I completely agree.
Yeah. Thank you so much, Dr. Wong, sir. There are no questions from the audience, but I think that's been a wonderful session and the audience has gained much, and it's a great eye-opener also for all those who don't use ultrasound. It has a great potential and great utility, and in the future it's going to be used more and more. So guys, please take this forward. Sir has given some websites also and references. Please use them, and it will be up on our YouTube channel soon. And Dr. Wong, sir, with your permission, shall we close this?
Yes, please. And I just want to say that thank you very much for the opportunity. If there's any further questions, I will keep an eye on the YouTube channel. If you've got any questions, comments, you post them on there. Any questions, I'll do my best to answer them.
Thank you so much, sir. Thank you very much. Thank you.
Okay, have a good day. Thank you.
Thank you, sir.